representative and you need to know, or it'll be also in the objectives. And there's pictures, so it's pretty thick. It's probably the biggest handout I make all year. It's 35 pages. Okay, we're going to start with GERD and peptic ulcer disease. So tell me what you know about GERD. Surely you've all at least had it at some point in your life. Maybe not, you're still young. But you drink, so that gives you some, or it gives you a gastritis instead. I shouldn't assume you all drink. So what do you know about GERD? Doesn't feel good. What's it feel like? Burning. Where is the burning?
Stomach to chest.
Substernal, from stomach up to your. So if you go to bed, if you eat a lot of foods that can aggravate or lower that esophageal sphincter tone, then you can wake up in the middle of the night with that acid taste in your mouth. Or they also call it like a water brackish taste. It's not very fun. Anything else?
Usually fatty, oily foods cause it.
Fatty foods can certainly do it. If that does, that's one thing to recommend to patients to decrease the amount of fat. What else?
It wears down on the linings.
Wears down the lining, so where do we worry about it the most?
The
And what would
esophagus.
that help that manifest itself?
Can cause Barrett's esophagus over time if you get a lot of scar tissue.
So Barrett's esophagitis is, the worry with it is what?
Precancer.
So it can lead to a esophageal adenocarcinoma. Okay. What else can you get from GERD? What are other complications of it? Ulcers, so esophageal erosions, yes. What else? If you have that acid come up high enough, what else can happen? So a lot of the erosions will occur down there near the juncture of the esophagus and the stomach. Pardon? What are you saying? Okay, if you get up in by your teeth a lot, we see that with bulimics, is that you get a dental erosion. What else? You constantly, you mentioned scarring, right? So that you get scarring higher up, and so they can have difficulty swallowing. So maybe the food will go down this far, and then they'll throw it back up. Sometimes they have trouble with liquids or solid foods. That is important to delineate. Can you swallow liquids? Usually water can find a place, right? But solid food's harder for them to get. So what do we do when people have esophageal strictures?
Open them up surgically.
We put a tube down and we blow it up. And we have to continue to do it because they'll continue to shrink down. So those are some of the complications of people who have chronic acid up in where it doesn't belong. So everybody has reflux, everyone. For the most part, it's something that's normal. The esophagus can recover, but it becomes abnormal when it then starts to disrupt the esophageal lining, causing symptoms. So that's when we call it GERD, and that's when we treat it. So let's kind of go over it first. So let's look at the drugs that you can use first, starting on page 3. So we have antacids, we have H2 receptor antagonists, and we have the PPIs. Those are your 3 drugs. They differ in their onset of relief, their duration of action, and their power to shut down the acid production in the stomach. And so we utilize all of those kinetic differences in how we treat people. As with most drugs that come on the market that are used, that have widespread application, eventually the bad parts of them will start showing up. And that's what we saw with the nonsteroidals. So you should have a very healthy respect for nonsteroidals because we've talked about the good that they can do, but they can also do a lot of harm. So the same with the PPIs. So when the PPIs came on, the proton pump inhibitors, very powerful, and they are very good drugs. But with overuse and over-the-counter use, so then what's happened is a lot of their side effects have started to pop up. So what I saw this year, at least in a lot of the recommendations, is there's kind of a decrease and a dampening now on the use of those proton pump inhibitors, somewhat more limiting and reserving them for the worst of the severe symptoms, frequent symptoms, or erosive esophagitis. One thing we're going to focus on with PPIs is the side effects, because they are sizable, and they are, some of them are, can be somewhat dangerous for folks. So if we look at the antacids, they are usually used on an as-needed basis because they're very quick. They're acid neutralizers, so once you put them into an acidic environment, they neutralize the acid, and that's a great irritant when it gets into the part of the body where it shouldn't be, and so it provides very fast relief. Likewise, it's very short, so about 30 to 60 minutes. So if you got somebody eating Tums all day long, that's a clue that they need probably some other acid suppressive therapy because the antacids aren't going to cut it. And what would be the problems? As you're looking down that list with using a lot of antacids, where could we get into trouble?
Renal function?
Okay, so renal function. So which of those are a problem with renal function?
All of them?
All of them. Which one's probably the more common or the more likely?
Yeah, the Tums.
Calcium.
Pardon?
Like with the Tums, the calcium carbonate, because you're,
Okay, tell me more. Say,
just because people will tend to just have a bottle of them and keep taking them without thinking about how many they're taking.
right, so calcium accumulation. Magnesium, remember that we talked a lot about magnesium levels and magnesium toxicity. So this is one of the more dangerous probably. You'd have to have fairly severe renal dysfunction to see that. But it can also cause diarrhea. Remember, we use it as a laxative. So that's common. Aluminum salts are very constipating. They also can accumulate in renal dysfunction. Often you will see most antacids are going to have a magnesium salt and an aluminum salt. So look at that second box next to both of them, because you see one tends to cause constipation, one tends to cause diarrhea. So when you combine them, you offset those effects, and usually most people can tolerate a magnesium, aluminum, antacid because you have that balance in there. And they're pretty effective. You get two different kind of mechanisms, so it's usually better to take them together. Okay. Or the calcium carbonate, they're effective as well. Just a note, I know OB was quite a while ago, but the calcium carbonate are the preferred in women. Magnesium is a smooth muscle relaxant, so if you give it to women late in pregnancy, you can delay them going into labor. Remember, we use that as a way for premature labors. We give them mag sulfate solutions, or IV solution. So calcium carbonate can also double up as their calcium source. So what kind of calcium intake do we recommend in women or men over 50? 1,200, under 50? 1,000. People are on steroids or other bone weakening type of drugs. What do we recommend? 1,500. Okay. All right. Okay, so that's antacids. It doesn't do anything to cure. It doesn't cure GERD, so it is only symptomatic. Okay, so we don't tend to. So you have to keep it in mind. That's why you don't want to see people using it a lot. Any indication that they're using it more than once a week probably need to go on to acid suppressive therapy. Let me get so.
I just had one. That milk syndrome, is that just for the calcium or is that all of it?
It's only for the milk. It's calcium overload. So that also puts you at cardiac risk. You take in too much calcium, you can augment or facilitate those calcium deposits in the artery. Jason.
I've always heard that taking those consistently can actually make GERD worse. Is that right? Does it like make your stomach think there's not enough acid, so it produces more?
You can see that with the H2 receptor antagonist, you can get a tachyphylaxis. Stomach will just overcome your effect, but don't know that with antacids. Who else? Someone else? Okay. So that's the antacids. The H2 receptor antagonists on page 4. So these are a different histamine receptor, so they have no effects on H1, so they don't tend to have anticholinergic or antihistamine effects like we see with the H1 receptor antagonist. So these are effective for mild to moderate GERD. They come in 2 dosage recommendations. If you look down in the chart, we have low dose and standard dose. That's kind of something new that's been introduced. A lot of the over-the-counter products are dosed or formulated for the lower dose. So for example, ranitidine, when it came out, its maximum dose is 150 milligrams twice a day. The over-the-counter is the 75 twice a day. So the lower dose is where we would start. That's kind of a difference you're seeing with the recommendations for GERD, is that we're going to start with a very minimal that will treat your symptoms, and we'll advance it up until we get symptom resolution. Then we leave it there for up to 8 weeks to try to take care of any changes that have happened in the esophagus while we work on other aggravating factors that are probably causing the GERD as well. Slower onset than the antacids. So you'll see products where when they have an antacid H2 receptor antagonist combined, and that's what they're trying to do. They're taking advantage of the very quick action of the antacid and a little bit slower with the H2 receptor antagonist. But they have pretty good duration of action, 4 to 10 hours, so you can dose them twice a day. No really need or indication to dose them more than twice a day. Sometimes people just take it at bedtime. If they only have GERD at bed, some will just take it once a day. You could even take a full dose at bedtime. Tachyphylaxis occurs. So this is something to keep in mind with this drug, is that we usually treat people for 8 weeks. So it is not uncommon for that dosing not to be effective later. So if they complain that, yes, I'm having GERD even though I'm taking the drug, it's more likely they've built up a resistance to it. So let's see, things down there to look at. You need to know those drugs are part of that drug class. You do not have to know the standard or low doses. What I do want you to recognize is that there are low doses and there are standard doses, and they're different. They're usually about 50%. The low dose is about 50% of the standard dose. They can be used on an as-needed basis. They act quick enough for a lot of people that they can use them as needed, as opposed to, similar to the antacids, as long as they realize that the onset is just a little bit slower. Questions about those? Okay, page 5. Here are the PPIs. You must know this page. I'm just telling you, it's really important. People can buy omeprazole over the counter, and they can use it, and people do that. So a lot of people are going to self-treat this until, most of the time, they're not going to show up in your office until their symptoms are severe enough that they can't get rid of them with binormal or whatever means that they have for them. So the PPIs are the drug of choice when you get to moderate to severe. They're very effective because they irreversibly bind the pump in the cells that produce or that exchange hydrogen for potassium. So if you can't get the hydrogen ion in, you effectively shut down the pump that helps to create the hydrochloric acid. So it's irreversible. The body has to produce new proton pumps in order to overcome it, and that takes time. So that's why these drugs are so effective, is because of that irreversible binding. Most of the time you can get away with once daily. If you have very severe erosive esophagitis, more erosive or very severe symptoms, you can dose them twice a day. They cannot be used on an as-needed basis. Their onset is way too long, 2 to 5 days. So you could use others. You could use an NS or an H2 receptor antagonist for those first few days. If they're really having lots of symptoms, if they're not that symptomatic, then you can wait and let that drug take effect. Okay, let's go through the side effects. So one thing to keep in mind is that the acid that we produce is helpful in many other ways besides helping us to digest our food. One is that it helps protect against organisms that can produce infection. So two things to keep in mind. Clostridium difficile is higher incidence in PPI users. And they can even get recurrent C. diff infections because they use them. This is a common side effect of PPIs. Patients will complain of diarrhea, not uncommon. Stomach cramps, diarrhea. If it's persistent, you need to think C. diff. And I don't know that that's always in people's kind of mindset when they're dealing with patients that are taking these. So keep that in mind. Also, pneumonia risk goes up. If there's an increased risk in community acquired, that's the most common. And then also with the healthcare associated pneumonia. So those are the in-hospital pneumonias. Malabsorption. We rely on acid a lot to convert drugs from one form into another. Remember ferric and ferrous with our iron? We rely on the acid to do that. So these four nutrients are ones to keep in mind. Iron and B12, you got to have intrinsic factor. Intrinsic factor production relies on acid production. You don't produce intrinsic factor, you can't absorb B12. So the effects on iron and B12 are clinically less significant. We can usually detect them, overcome them, treat. If we have to have acid suppressive therapy, then we can supplement them. So those two, while they are very common, they are not as significant as the last two, which is magnesium and calcium absorption. If they are on long term and they have a diet that's say it's low in magnesium, then you can see hypomagnesemia, and it can be significant in these folks, as can be calcium absorption. That was one of the early fears with using these agents, is that you could not absorb calcium as well, and so it would lead to an increase in osteoporosis, increase in fractures, and those are real side effects associated with the long-term use of these drugs. So people who have severe or frequent or erosive gastritis, or if they're not gastritis, but esophagitis, or they're at risk for Barrett's, they're going to be on these drugs for years. So that's where the problem comes into. If you've got somebody on an 8-week therapy and they get off and they're doing fine, risk is extremely low. It's the long-term chronic year-on-year users. Kidney disease. This was one of the more minor ones that we talked about, but it can increase the risk of acute interstitial nephritis. Also chronic kidney disease, the progression of renal disease to end-stage renal disease. So kind of keep that in mind, because think about it, commonly we'll say if people have to take non-steroidals long-term, what do? We recommend they take a PPI. So keep those in mind for your higher risk patients. That's where it's mostly going to impact. Drug-induced lupus. Until I did this review, I had never been aware that this is a possibility. So the PPIs can induce a cutaneous lupus, so a discoid lupus, or a systemic lupus. And they can occur any time in therapy, within starting the drug or after years of taking the drug. And they can also exacerbate existing lupus as well. With the cutaneous or the discoid, it is usually subacute, subclinical, often missed. With the systemic lupus, it presents like we usually see lupus present, which usually was with a rash, that malar rash on the face. One of the more recent problems that have been identified with the PPIs is an increase in all-cause mortality. There was a study done, a fairly large study done of PPI users, and they found that compared to placebo and to H2 receptor antagonists, the risk of death was higher in the patients who use PPIs. So that went out all over the press. But if you look at the study, it is not very generalizable. It was men, they're white men over the age of 60. So can we apply it to younger group, to ethnic groups, to women? Well, it's harder to do that because of who they included. But it does raise the issue that there may be something there. And it may be that it's more problematic in an older population. So that is one to watch. So the takeaway message is respect the drug. And even though it seems to be fairly well tolerated by the majority of people that you see, you have to respect that it can have significant side effects, particularly in those that are more at risk for other problems occurring. So your older patients, people are on multiple drugs, cardiac, renal, those are the ones to kind of keep an eye on. Questions about those? Okay, let's look at the next page, counseling points. This is really important. I see most of the time when I'm working with patients that are on PPIs, they never take them right. So your highest pump concentration in the stomach is in the morning. And because you fasted all night, those pumps upregulate, they get ready for you to eat. So it's important that they take the drug for maximum effectiveness. You want to take it about 30 minutes before you eat. Get it in the system, get it down in there, and it will shut those pumps down. Because as soon as you start eating, those pumps become active. And so your drug just has less ability to exert an effect. So first thing in the morning before they eat, best effect. You can use it at night for people who have nighttime symptoms. I've also found for more minor GERD, adding an H2 receptor antagonist at night also works. That's just my experience. So sometimes patients will do that PRN. It really is not an on-demand drug like the H2 receptor antagonists and antacids. So this is one that needs to be taken on a regular basis to be effective. One drug interaction to remember, if you call it back up, we talked about it when we did, not under the anticoagulants, when we did the ischemic heart disease, and we talked about acute, and the antiplatelets. This is where this came up. So omeprazole and clopidogrel. So remember, clopidogrel is Plavix. It's an antiplatelet, one of the common ones used. It's one of the more unusual in that it has 2 steps to the conversion to active drugs. So it's a prodrug, has to be converted by 2 different enzyme systems in the liver, the 2C19 and 3A4. Okay, so omeprazole hits both of those. Most of the PPIs will interact with those enzyme systems. They'll either serve as a competitive substrate or they're inhibitors. So what happens with clopidogrel is that when patients have used those in combinations and they've looked at studies of patients in that drug interaction, they have found more cardiac events in those patients who were on a PPI that took clopidogrel. So the recommendations, if you have to use it, consider pantoprazole because it has much less effect on the enzyme systems that affect clopidogrel, or use a different antiplatelet. That's another option. You'll notice I've said there's 6. There are more than what I put down. These are the most common. I've also kind of highlighted the end of that. It's easy to remember because they all end in prazole. So it's one way to remember the class. I want you to know those drugs that belong to the class. You do not have to know the doses. Also know that there is a low dose and a standard dose. The difference here is usually low dose is once a day and the standard is twice a day. I really didn't indicate that on the Well, okay, forget that. So the lower dose, standard dose also can sometimes infer twice daily. You'll see that in recommendations as well, but I didn't put that. Also, delete out the italics. I changed my mind and I didn't take it out of there where it says you're only responsible for our omeprazole as a representative of the class. I want you to be able to put those drugs in under as a PPI. Okay, questions about those?
Did you say the low dose was usually twice a day or once?
No, the standard dose, sometimes they'll do that as a twice daily standard dose, but
Okay,
low dose, just know there's a low dose option and a standard dose.
okay.
Usually the recommendations start with the low dose and then titrate them up to standard if they don't respond. The last one is sucralfate. So we've talked about sucralfate a couple of times. It is a non-absorbable binder that will bind to exposed tissue, and it forms a protective barrier, and it just sits there. It doesn't get absorbed. It's just a barrier. It acts as a barrier until the underlying tissue can regenerate and heal itself. Not used that common because it has to be dosed 4 times a day in order to be effective. We've talked about it in pregnancy. It's preferred in pregnancy because it is not absorbed. It has very few side effects, but really the main problem is that the number of times it has to be taken a day. It does have aluminum in it, so you can see some constipation, renal function you would avoid. So there is some increase, or there is some absorption of aluminum, but not of the active drug itself. Okay. Questions? So a lot of drugs that you've heard before, and also you know about, I know you've also used them at Good Shepherd. They're fairly common. You deal with adults, you'll see them a lot. And same with kids. One of the things with kids we start worrying about is if you're doing everything, you're pretty sure of your diagnosis, one thing you start to think about, and also with overweight adults at risk for GERD, is that it's one of the causes of asthma. It'll aggravate. It'll be a secondary. So people have new onset asthma as an adult, or in kids that worsens their existing asthma. Think acid reflux. Okay, so GERD, one of the most common digestive diseases in adults. We talked about the symptoms, we talked about the complications. I put down there the indications for upper endoscopy, not because that is my area, but I liked the fact that they kind of listed risk factors for the different problems. So alarm features, I think those are important to look at because a lot of people are going to have GERD, but when do you really get excited about it? Well, here are some of the ones. Dysphagia, so they're having trouble eating, pain in eating, food gets stuck, they vomit food, undigested food, those are commonly associated with more severe esophageal disease and strictures. GI bleeding, uncommon to see that, but it is very worrisome that they have that much erosion that they're bleeding. Anemia, so it's suggesting an ongoing blood loss. Weight loss, recurrent vomiting. Okay? So those with GERD are very significant. Most people are not going to have that. Who's at risk for Barrett's and who should you screen? So screening would mean you've got to do an endoscopy. So don't want to do an endoscopy on everybody who has GERD. So who would be the most? Chronic GERD, history of hiatal hernias, the older adults, males, white, elevated BMI, especially more apple. So the more fat they've got around the central adiposity, those are your risk factors. Post-treatment evaluation, also wanted to add that for certain severe GERD, you would want to, after you've treated them, to go back in and look to see is there still any erosions or are the Barrett's esophagitis still present. Those would be important. or in people who have persistent. You treated them for 8 weeks and they persist to have symptoms of GERD throughout the treatment or once it's discontinued, which a lot of people will. Okay, page 9, top of page 9. So therapy is directed at these 6 things. One is we want to reduce the acid. We want to decrease the gastric volume of acid. We want to get improved emptying of the stomach. The better you empty, the more you get those contents out of the way and less likely that they can reflux up into your esophagus. Increase the lower esophageal sphincter tone. There really aren't drugs that do that. Mostly it's getting rid of things that aggravate or lower that sphincter tone. Enhancing esophageal acid clearance and protecting the esophageal mucosa. So our goals of treatment are to eliminate their symptoms, because that's usually why they're going to come to you. Decrease the frequency and occurrence of reflux, promote healing of the injured mucosa, and prevent the complications. So one of the first places to start is lifestyle. A lot of GERD is a result of what we do. And so targeting those triggers, having patients self-identify, usually they know what brings it on, or giving them some guidelines as to how to handle, like when to eat your last meal. I can't tell you how many patients I had at family medicine is that they eat at 9 or 10 o'clock at night and then they go to bed. Well, that usually is a setup for GERD. So there are 2, and I've highlighted them if you're looking at color, and I don't know if they show up in your, yep, they do. So these 2 actually have data behind them that say they work, so the 2 that I've done. So one of them is elevating head of bed. So you can do that, and this would be for people that have nighttime symptoms, laryngeal symptoms, so there's that cough, hoarseness, asthma, worsening, throat clearing. And advise them not to lay down after they eat. So don't do the Thanksgiving routine. Eat a big meal and then go lay on the couch. Don't do that. Stay upright. And the other is weight reduction in obese. These 2 have evidence to show they're effective. So elevating the head of the bed, I've already find difficult. So there are, if you go on the internet, you can find different ways. They make styrofoam wedges that you can put under the mattress that will elevate it. If you look on the next page, there is this tells you how sad it's become. There is a reflux board that you can get to have patients lie on that elevates at least 6 to 8 inches to just allow gravity to keep the contents down where they belong. So those 2 are important. I have had patients who have slid out of bed, or they do it too much, or they slide to the footboard. I don't know how comfortable and practical that is, because patients can certainly roll down the bed in the middle of the night. I don't find that most people adhere to that, but that doesn't mean that it isn't worth investigating or using. The other are the avoidance of certain foods. So foods that lower esophageal tone are chocolate, caffeine, the alcohol, peppermint, fats, spearmint. So getting people to decrease the use of those. Chocolate and coffee, I cannot give up. That would be very hard. There are drugs, the calcium channel blockers, you might add those. I didn't put them in, but there are certainly drugs that will do that as well. Avoid foods that have direct irritant effects. So patients probably can tell you those are spicier, the citrus fruits, tomato juice, caffeine as well. Recommend that they lower the amount of food they eat at any one time. If they eat one large meal and then very little in the day, that's probably a problem. So if they can divide them up, that may be of help. Avoid eating prior to sleep. So advise them at least 3 hours in between the meal and when they lay down for bed. Stop smoking. That's one of those give-me's all the time. Avoiding alcohol. Alcohol will often cause GERD, especially if people drink it late at night and then lay down. Avoid tight-fitting clothes. So I read some about this and they said it's always a recommendation, but they don't really know if it matters. I always said it more to those, men that are older and they wear, their waists are about this big, but their bellies are about this big, and they wear those tight jeans right under their belly, and so they've just kind of got a constant push up of the stomach. So I don't know. It might be something to advise and then people to try. Drugs that have direct irritant effects on the esophageal mucosa, taking with plenty of water. So we talked about this with the bisphosphonates, is remaining upright for at least 30 minutes and drinking a full glass of water to make sure the drug gets down into the stomach and doesn't hang up in the esophagus. So those can cause a lot of erosions. That's one of the reasons why it has you've got to be able to sit up 30 minutes at least after you take it. Tetracyclines, potassium chloride, the tablets are very big, so they can get hung up, especially if you have strictures, and they're also very ulcerating. Iron salts, aspirin, non-steroidals. It's amazing to me people that pop in pills and never drink any water with them. Your age, you can probably get away with that. Older people can't. So always taking pills with a full glass of water is a good idea. So how are you going to use the drug? So start with lifestyle. If that doesn't work, then add a low-dose H2 receptor antagonist. So this would be like the ranitidine, 75 milligrams twice a day. Always advising them lifestyle. Most of the time it is very hard for drugs to overcome what we do to ourselves. And also advise patients that usually making those changes doesn't cause side effects, and I don't have to monitor you, I don't have to draw blood. So encourage that. And then PRN antacids if needed on top, but you really have got to monitor that, because if they're using it a lot, the PRN antacids, then it tells you that the underlying acid suppression isn't enough, or what they're doing or practicing is overwhelming. Most of the time we can do a lot ourselves to overrun any kind of therapy that is prescribed. Reminding that the antacids don't cure GERD. H2 antagonist will, the receptor antagonists, and PPIs, but not antacids. If symptoms are not controlled on that low dose, and they recommend going about 2 weeks with a drug dose before you increase it. So at that point, if you're not getting the response you want to the low dose, then go up to the standard dose for 2 weeks. If that doesn't work, then discontinue the H2 receptor antagonists and start them on a low dose of PPI. Usually in most people, if you're talking about mild to moderate, that's going to do it. And then leave them on it for 8 weeks. That should cause enough healing. Hopefully they can make enough lifestyle adjustments that when you stop the drug, they'll be okay. Most people will have symptoms return. It's common. Because most people don't make the changes, or there's enough damage there, or changes in the construction of that area that it'll never go back to normal. If you have severe or frequent, then you start, or erosive esophagitis, you start with the PPIs. The H2 receptor antagonists are not strong enough to treat the erosive esophagitis, so we start with the PPIs, a low dose, plus the lifestyle and the dietary modifications. And you see there that it's very effective. 86% of patients will have a resolution of their symptoms and a healing in that area. There's no difference in different PPIs. Go with the cheapest or the one that their insurance will pay for. Often insurances, if there are drugs over the counter, they will not pay for that. They'll force the patient into purchasing themselves. They aren't the cheapest of the over-the-counter products, but they're not bad in terms of cost. Let's see. So that's severe, frequent, or erosive esophagitis. If symptoms return or maintenance therapy, what do you do about that? Well, 2/3 of people are gonna relapse when you take them off. They still recommend, because the drugs have significant side effects, is that once you've done an 8-week treatment trial, is take them off anyway and see what happens. And because if you've got 1/3 of people who are going to do fine, then that's 1/3 who don't have to continue to take medications. Patients who have a severe esophagitis or are at high risk for Barrett's esophagitis or a esophageal cancer, those people need to stay on suppressive therapy. And there we would use a PPI. And then you can step up or step down, just depending on how people respond. If they're doing great and you got them on the standard dose of a PPI, you could always back down to a low dose and see if that contains it. Okay, questions about GERD? Yes?
I know on over-the-counter PPIs, they are like dosed for 14 days. Is that just to keep them from taking them recurrently, or?
That's probably what the FDA would approve.
Okay.
So that doesn't have any bearing. If you instruct them to do that, that doesn't stop them. That's FDA approval for over-the-counter use. Good question, because they'll bring that to you. Because you're right, some of them pack them now in 3 bottles of 14, which is 6 weeks, so I don't get that either. I'm not quite sure where that one came from. Okay, well, since we're gonna get about ready to start a new topic, let's just go ahead and break and come back a few minutes before